Good morning. On behalf of all of us here at the Cooper Institute, we want to welcome you to the Coffee with Cooper virtual series that focuses on taking control of your health and working towards a healthier future. This series will present up-to-date health and wellness information and offer suggestions for healthier living based on proven science. At the end, we will provide time to answer questions from attendees. My name is Laura DeFina. I'm the president and CEO of the Cooper Institute. For those of you who want to know more about us at the Cooper Institute, we're a nonprofit that was established in 1970 by Dr. Kenneth H. Cooper to promote lifelong health and wellness through research, education, and advocacy. By improving public health, the Cooper Institute helps people lead better, longer lives now and well into the future. It is my pleasure today to welcome Dr. Nina Radford. Dr. Radford is a research colleague at the Cooper Clinic. She received her Bachelor of Arts from Cornell University and her medical degree from Mount Sinai School of Medicine. She then went on to complete her internal medicine internship and residency, as well as cardiology fellowship at the University of Texas Southwestern Medical School affiliated hospitals. Dr. Radford also completed a fellowship at the American Heart Association Berger Foundation Centers for Molecular Biology in the cardiovascular system. She is certified in internal medicine with a subspecialty in cardiovascular disease by the American Board of Internal Medicine. I'm most excited to note that she also is on the Board of Trustees of the Cooper Institute. Dr. Radford is here to talk to us today on understanding coronary artery disease risk prediction. We will have a few minutes at the end for Dr. Radford to answer the advanced questions you have submitted, and you can also use the Q&A function on your Zoom application, and we will get to as many of those questions as we can at the end. And with that, I would like to introduce Dr. Radford.
Thank you, Dr. DeFina. It's my pleasure to be here. Laura and I have worked together for, has it been 20 years when we started?
Been a while.
19, 18, we're so youthful, but it's my pleasure. And I'm on the board at the Cooper Institute. I've also am a research colleague. I've participated in a number of research publications with the Institute. So again, it's my pleasure to be here. What we're going to talk about for the next 20 minutes or so is understanding coronary artery disease risk prediction. And the reason this is important is that we like to target therapies and interventions for people who are at the highest risk. And so is there a way that we can assess that well before a patient has a cardiovascular event like a heart attack or a stroke? So to begin, let's talk about, there we go, what specifically we're talking about when we talk about coronary heart disease, because cardiovascular disease takes many forms, heart rhythm problems, heart failure problems. What we're going to talk about primarily this morning when we talk about coronary artery disease is atherosclerotic vascular disease. And this is hardening of the arteries, arterial sclerosis, plaque. It has a lot of different names. And this is the buildup that occurs in the heart arteries on the, I'm not sure what side of the screen it is for you, but you'll see on one half of the screen, there is a cross section of a healthy artery. And you'll see that it is covered with fatty material deposited in the vessel wall. That's a coronary blockage, atherosclerosis. And on the other side, you'll see a diagram or a picture of the heart, and it's got the heart arteries coursing on the surface. And when these arteries get sufficiently clogged, you may have symptoms of chest pain or chest pressure. And if these plaques rupture and cause the development of a blood clot on a plaque, a heart attack can actually result as a consequence of loss of blood flow to that part of the heart muscle. So what we're going to talk about this morning is what are the risk factors that put an individual at higher risk for developing this fatty material or atherosclerosis in the coronary arteries. So the process is a complicated one, and I'm showing a picture here of how this atherosclerosis begins. And it really begins with the LDL particle, which is floating in the bloodstream towards the top of the slide. And that LDL particle, the bad cholesterol, gets through the thin lining of the blood vessel called the intima, gets underneath the surface, interacts with some of our normal inflammatory cells like macrophages, turns into a foam cell, and you get the buildup or a bulge there of atherosclerosis. And there are a lot of mediators to this process. It just doesn't involve the LDL particle. It's highly influenced by processes like inflammation. But the LDL particle has always sort of been a really central figure in terms of our prevention strategies. So again, this is another picture of cross sections of arteries. You'll see we get some beginning of atherosclerosis, which is sort of this yellow stuff right here. This is where the blood is flowing. And over time, with the process of inflammation and healing, a little bit of calcification, microcalcifications can start to collect in this plaque. Those are demonstrated by high-tech things like PET scanning. And this plaque can become unstable, rupture, forming the heart attack there, or after it can become inflamed and then healed. And over time, you get these macro calcifications, which we can see on CT, and we'll talk about those a little bit later in the talk. Now, when we talk about identification of risk factors for atherosclerosis, I can't help but talk a little bit about history. I am no spring chicken, and I trained at a time when some of these risk factors were not well described, when statins were initially FDA approved, occurred during my training. And so I like to talk a little bit about how these risk factors were identified early on, because I think it really impacts some of the limitations of any of these risk prediction programs. So back in 1948, the Framingham heart study was initiated. And in 49, the NHLBI, the National Institutes of Health, took it over. And this was a study that basically looked at about 5,200 healthy residents in Framingham, Massachusetts. And this is a small suburb of Boston. And they actually happened to pick it because they did a very successful tuberculosis study there in, I think, 1918. And it was close to the big Boston hospitals. And it was a group that really sort of, as a community, bought into the importance of advancing medical knowledge and science. And these individuals between the ages of 30 and 60 years had examinations that they started in, I believe, 1971 to 1974, or I'm sorry, that they started right back in 1948. And then they would have these comprehensive physical exams and complete these comprehensive histories over time. So they would say, yes, since I saw you last, I had a heart attack, or I've had this, or I've had that, and these are my risk factors. I've gained weight, my cholesterol's bad, I'm getting diabetes. In 1971, they added the offspring study, which were the sons and daughters and spouses of this original cohort. And then in 2002, they started the third generation cohort. And the importance of all of this was that they could incorporate, as they gain knowledge, history of different risk factors and what happened because of those. And so this timeline, again, shows when the Framingham heart study started. In 1957, it was identified really for the first time that high blood pressure and cholesterol increased the risk of heart disease. And the concept of, a risk factor at all was introduced in 1961. And over time, they started to accumulate data that associated these different risk factors with disease. Now, that's kind of the first part of the puzzle to say, yes, high cholesterol is associated with heart disease. And then there's a whole kind of second wave of studies where we actually prove that treating those things make you live longer. And so, for example, you can see that in 1967, physical activity was associated with heart disease, but it wasn't until the pivotal studies at the Institute that showed actually improving physical activity made you live longer. And so, there's sort of two parts to the puzzle. One, associating risk, and then two, showing that if you do something about it, it matters. So again, the contribution of the Framingham investigators was they were able to develop these statistical models to predict your risk of heart disease. You put in, different variables, you crunch the numbers, and then you said, well, over the next 10 years, I think you have a certain risk of developing a fatal or a non-fatal heart attack. And it really helped physicians identify what patients might be at greater risk for having heart attacks, so that then they could target therapy towards those people. Now, so when you look at what did they look at? They looked at gender. So there was a separate set of calculations for men versus women. They looked at age, HDL, which is the good cholesterol, LDL, your bad cholesterol, or else total cholesterol, the presence or absence of diabetes, the high blood pressure, and the presence or absence of smoking. And even these, for example, for smoking, if you smoked anything in the last year, you were considered a smoker. And if you didn't, you were considered a non-smoker. Now, that's not perfect, because what if I smoked like a chimney for 30 years, quit 2 years ago? So technically you would call me a non-smoker, but am I really the same risk as someone who never, ever touched a cigarette? And so they did do kind of levels of gradation with HDL, LDL, and blood pressure, looking at whether or not your LDL was medium high or super high, looking at if your blood pressure was just a little bit high or, again, very, very high. And what they did with this Framingham risk score is you would come out with a number of what is your risk of having a fatal or non-fatal heart attack over the next 10 years. So, for example, they said, well, gosh, if you have 0 to 1 risk factors, you don't even have to calculate the risk. But if your LDL is really high, consider cholesterol lowering. So if you smoke like a chimney, and your LDL was 160, I'm like, well, good luck with that. Now, they considered 0 to 10% low risk, 10 to 20% intermediate risk, and greater than 20% high risk. And I always thought it was interesting. So low risk is 0 to 10%. So if you were 9%, say that was a 1 out of 12 chance over the next 10 years of having a non-fatal or fatal heart attack, to me, it seems sort of high. And although therapies were not directed to that risk, if you said, well, gosh, you have a 1 out of 12 chance of getting, winning the lottery in the next 10 years, I'd kind of be feeling lucky. So it's sort of interesting when you look at what these risks are. And basically, based on this risk, they would make recommendations about lipid lowering therapy, again, primarily in the form of statin medications. And again, the thresholds for treatment way back then were, if you were super high risk, greater than 20%, or you had a CHD risk equivalent, which was having had a stroke or being a diabetic, they really wanted the LDL below 100. And now, of course, we know that in the most recent trials with PCSK9 inhibitors, we're seeing LDLs in 20, 30, and 40. So over time, our thresholds for what are reasonable therapeutic goals have also changed. Now, absolutely, the Framingham risk score had a lot of limitations. All the participants were Caucasian. They were all from a single suburb of Boston that kind of had this civil community sort of drive to participate in these kinds of cohorts. And so are those different from kind of the average bear in a big city? Young patients were very underrepresented and had few coronary events in this cohort. And that has the impact that you will miscalculate what their risk is. And there was one study that showed that if you looked at the young men under the age of 55 and young women under the age of 65, 70% of them who had an acute heart attack as their first coronary heart disease event, they were classified as low risk. And in fact, they were obviously going to be high risk. The other thing, as you probably noticed, is few risk factors are included. And, unhealthy diet, sedentary lifestyle, strong family history, lots of belly fat, all the things that we know now contribute to risk were simply not included back then. We also, this is about heart attack and it's not about stroke risk. And yet we know a lot of the risk factors that predispose you to developing hardening of the arteries in the heart also affect the large arteries in the neck, which can translate to your risk of stroke. So in 2013, the Framingham risk score was really replaced by something called the pooled cohort equation. And this was an improvement on the prior Framingham risk because it included African Americans. It also had an expanded endpoint of stroke. So it was going to predict your risk of both non-fatal and fatal heart attack, non-fatal and fatal stroke. It also sought cohorts that were representative of the US population as a whole, and it picked cohorts from different parts of the country that were community or population based. And they included in these contemporary cohorts, these people were living in more contemporary settings, stress, air pollution, the benefits of automation where you no longer had to hang your laundry out on the line and you stuck it in the dryer, and you didn't have a push mower, you had a gasoline powered mower, which affected physical activity and so on. So it was a cohort that kind of reflected the modern times of how we live. So that was definitely a benefit. So this is an example of sort of how it worked, that you put in your sex, your age, your race, total cholesterol, HDL, which is your good cholesterol, just the systolic blood pressure, identified again if you were on treatment for high blood pressure, if you were diabetes or a smoker. And you'll notice that this is, they have treatment for high blood pressure, but they don't have treatment for cholesterol, for example. And that's because these cohort equations, almost all the risk prediction tools, are really aimed at answering the question, does this person need a statin medication? And so this is for people not on a statin medication. You're going to calculate a risk and decide, are they low risk, medium risk, high risk? Do we say they ought to have aggressive cholesterol management? Back in the day, it impacted whether or not we thought you ought to take a baby aspirin. And it compares the risk to someone who has what they call optimal values. And back then, they said an optimal total cholesterol was 170, HDL was 50, systolic blood pressure was 110. You didn't take medicines for blood pressure, you didn't have diabetes, and you weren't a smoker. And so it was based on the numbers that were generated from this new risk assessment tool that we would calculate your 10-year risk of heart attack or stroke, and then make recommendations about whether or not we thought you were high risk enough to be treated with a statin medication, for example. Well, I will tell you, when these came out, there was a lot of drama, lots and lots of drama and controversy, because basically, when you put in someone's numbers, if you were basically a Caucasian man over the age of 65, even if you had pretty good risk factors, because age and gender were strong predictors of risk, that you were a statin candidate. I mean, basically, put statins in the water because everyone's going to test high and need them. And so, there was a lot of debate in the literature. There are major limitations that undermine the clinical utility of this calculator that must be considered by clinicians to avoid unintended consequences. And I remember Mayo Clinic came out with their own modifications that they thought that, the the pooled cohort equations weren't perfect and that we really needed to make these estimates. Now, the other thing is, again, didn't include those novel risk factors like sedentary lifestyle, family history of premature heart disease, belly fat, lousy diet, stress, obstructive sleep apnea. There's a gazillion things that may impact risk. And it was thought when they applied these pool cohort equations that when they applied them to real groups of people to see how well did these predict risk, what they found was it probably overestimated the risk in Blacks and whites. It underestimated the risks in South Asian Americans and likely overestimated the risk in East Asian Americans and Hispanics. So again, not perfect, better than a poke in the eye, but certainly not perfect in terms of identifying risk. And there was a lot of discussion with individual patients about sort of where they fell outside of the lines in terms of these, the risk calculator. Now, in 2019, these risk equations were not modified, but the interpretation of the risk was modified. And again, the 2019 primary prevention guidelines said, if your age is 40 to 75, you really ought to have your 10-year risk estimation done, and then talk to your physician about whether or not you ought to start on drug therapy for high blood pressure, statin medications, aspirin, for example. And for the first time, they actually added an impact from those risk enhancing factors. And they also added the use of coronary artery calcification scanning, or the CAC score. And again, we'll talk about that in a minute. So this is sort of the schema. And as you can see, it's pretty complicated. And basically, can I scoot this thing up so I can see what I'm saying? Okay, thank you. So I'm not very technical, so I have to have a right-hand woman here to help me. So, basically that if you're 0 to 19 years of age, we don't have a risk calculator for you. We want to identify if you have some terrible high cholesterol that runs in families, familial hyperlipidemia. If you are 20 to 39, our risk predictors still don't apply to you because age is such a strong predictor of risk. And these risks are predicted for the next 10 years, but there is this concept of lifetime risk that can be calculated. And then again, if you're 40 to 75 and you don't have diabetes, you ought to have this risk predictor done. Now, in general, if you have a super high LDL, which is above 190, they say, we don't even need to do any additional testing, go straight to the statin medication, high dose, you're in big trouble. Again, if you have diabetes, that is a big risk for heart disease. Just don't pass go, just go straight, pass go straight to that moderate statin. And even maybe a high intensity statin because diabetes is not good. And then if you're over the age of 75, there is some discussion about whether or not, the statin type therapies prolong your life. And again, this is all primary prevention. You haven't had an event before. And I think subsequently there have been some studies that suggest that there is benefit even in older people. And I always sort of talk about physiologic age. I have very, many patients who are, 78, 80, 82, they're going and blowing. They have a decade or two of great living in front of them. And so I don't really treat them any differently in terms of wanting to prevent the risk of heart attack or stroke. So again, we're going to go on to our online risk calculator. We're going to generate a number. And then based on whether or not you're low risk, and that's less than 5% chance of having non-fatal or fatal heart attack, non-fatal or fatal stroke over the next 10 years, 5 to 7.4% is borderline, 7.5 to under 20 is intermediate. Again, greater than 20 is high risk. And then on that, if you're high risk, go straight to get a statin drug, drop your LDL by 50%. If you're low risk, you know what? Don't eat fried lard, get some exercise, quit smoking, and we're going to talk about your lifestyle. When you talk about sort of these borderline or intermediate risks, in that situation, it is reasonable, if you're not sure if the patient really needs to be treated with a cholesterol medication, to talk about risk enhancers. And we'll talk about that in a minute. So what does the risk calculator look like? And there may be a lot of people who've already done this with their healthcare providers, or some people who are interested in doing it. Remember, and if you look up ASCVD Risk Estimator Plus, it's the American College of Cardiology has a website where you can just plug and play. And again, this is primary prevention. You haven't had a heart attack, you haven't had a stroke, you don't have a big aortic aneurysm, and it's in patients 40 to 70. This one, 70 and 79, but it'll give you a lifetime risk for the younger folks, but 40 to 75, you definitely need to look at your short-term risk. And so it will ask you, man or woman, white, African-American or other, top blood pressure number, bottom blood pressure number, total cholesterol, good cholesterol, bad cholesterol. Do you have a history of diabetes, current, former, or never smoker, on treatment for high blood pressure, already taking a statin medicine, or already on aspirin therapy? And it was going to calculate a number for you. So I'm going to give you an example here. Here's just something I plugged in. 57-year-old woman who's Caucasian, blood pressure is 128/70, total cholesterol 193, HDL is pretty good, 74, LDL looks great, 104. No diabetes, never been a smoker. Yes, taking blood pressure meds, not on a statin, doesn't take aspirin. And so this person, this woman, has a 10-year risk of 2.5%. That's low. Remember, it's less than 5%. And this compares to someone who has optimal risk factors of 1.7. So a little bit higher, but not super high risk. They also give you a button to push that says, what is the impact of therapy? So this person had a systolic blood pressure of 128. In an ideal world, we'd have that below 120. And so they said, if you add a blood pressure med to get the blood pressure better, you're going to drop that risk by 1.8%. So it not only shows you what your risk is, but if you add therapies, how do you impact that risk? Because often, and it would rightly so, a patient will say, well, if I start that medication, will it make me live longer? And that's an important, question to answer because meds have side effects, they're expensive, you have to do follow-up. So, we all like to know that it's actually going to hopefully make you live longer and better. So here's another example. This is a 64-year-old man, Caucasian man, got a little bit of high blood pressure, 134/82, total cholesterol 220, HDL 50, LDL 150. No diabetes, never smoked, not on blood pressure meds, not on a statin, not on aspirin therapy. Here we have a risk of 13.6. Intermediate risk, if this person had good risk factor control, it would be 8.1. Still not low, but a little less than, a little more than half. And again, if this person decided to add a statin medication and start blood pressure medication, the risk could actually be reduced quite substantially. So again, this is for patients who haven't had heart disease or a stroke. And this can look at the impact of starting various therapies on your risk. Now, this adds risk enhancers. So it doesn't give you an opportunity to plug in yes, no, just how fat is your belly, how many belt loops, can you not tighten? But it does say, take into consideration these different individual components, which may increase your risk. So if you say, well, I'm borderline for starting a cholesterol medicine, but maybe let's look at what else is going on. And so what are those risk enhancing factors? Again, we talked about the importance of a family history of premature atherosclerotic cardiovascular disease and Premature means you had it when you were younger. And so that means men below the age of 55, women below the age of 65. So if your dad had a heart attack running a marathon at 99, we would not consider that premature coronary heart disease. But if people in your family, brothers, parents, children, adult children have early onset, that's something to be concerned about. Also, if your LDL is high, now not the magic 190 number where you automatically go to a statin, but if it's high, let's reconsider whether or not therapy is required. Metabolic syndrome, and that's a combination of risk factors where you got a big tummy, your triglycerides are high, your blood pressure is high, your blood sugar is high, your good cholesterol is low. It's kind of the precursor to frank diabetes. If you have chronic kidney disease and chronic inflammatory conditions. And again, this, inflammatory conditions like psoriasis, lupus, rheumatoid arthritis, HIV, AIDS, they do increase the risk of cardiovascular disease events. And I know there are a number of rheumatologists who are very aggressive with their patients who have inflammatory arthritis in terms of managing risk. Let's see, let me go back. Oops, go back a minute here. Other risk enhancing factors, we know that if a woman has a premature menopause before the age of 50, or if she has pregnancy associated conditions that will later increase risk, like preeclampsia, those are risk enhancing factors. South Asian ancestry, lipid biomarkers like triglycerides that are high, HSCRP, C-reactive protein, which is a marker of inflammation, is high. Lp(a) is another kind of cholesterol lipid component. ApoB level high, and ABI less than 0.9, and that means that you have peripheral vascular disease, hardening of the arteries in the legs. Those are other things that you would consider, that if you're on the fence, but you had premature menopause, your HSCRP is up, your mom had a heart attack at 60, those are all things that are going to influence us more towards being more worried about risk. How am I doing on time? Am I good? Oh, I'm running over. This is the story of my life, but this is just so interesting. So let's turn now in the last couple of minutes to, if the decision is uncertain, that consider getting a CAC score, or coronary artery calcification score. And so this takes advantage of the fact that when blockage, atherosclerosis first starts, it starts as foam cells, you get all this lipids, this goopy core, and over time, as that surface, the fibrous plaque becomes inflamed and healed, sorry about that, you will develop calcification. And it's macro calcification. This is a process, again, that features inflammatory, metabolic, a bunch of chemoattractants, and it is, again, a marker of advanced disease. If you have calcified plaque, it means you've probably had soft plaque for at least 10 years before, and early autopsy studies showed that if you have soft plaque, there's probably about 5 times, if you have calcified plaque or hard plaque, there's probably about 5 times as much soft plaque coming up behind it. So they talk about, hard plaque is sort of the tip of the iceberg. So how do we identify that? Obviously having it identified at autopsy does not make the preventive cardiologist look very good. Well, we identify it on a CT scan. And so here, the heart arteries conveniently lay right on the surface of the heart. We will see these areas of calcification in the distribution of those arteries. It is using a software program, they get a volume, and then it's converted to a score called by using something called the Agatston equation, and you get a score. So 0 means we don't see any calcified plaque. It doesn't mean you couldn't have a lot of soft plaque. So it's not a permission to supersize your fries. And then we will get a CAC score that we will look at separately, men from women. We look at the absolute score, and we also look at your percentile rank. And so when we talk about absolute scores, they're often categorized. CAC is 0, CAC 1 to 100, CAC 100 to 400, and CAC greater than 400, with CAC being greater than 400 being high risk. And so the importance about the calcification to me is that I don't really have to rely on the mumbo jumbo crystal ball of predictive models where I put in your numbers and hope for the best. If you have calcified plaque, I know you have hardening of the arteries. This is not a mystery anymore. You have got plaque, which means you have atherosclerosis in the heart arteries. Now, it doesn't tell me, is it in a tight lesion? Is it in just, little lumpy bumpies? But it tells me you are forming plaque. It's not a mystery. Now, this is to describe sort of how CAC adds traditional risk factor models. You say, well, Nina, I've had my cholesterol, blah, blah, blah. Do I really need this CAC score to better define risk? And I think it's important to note that, this was a really huge study of, I think, 45,000 people who got CAC scores, and it looked at their standard risks. And if you'll see here, this is individuals who have 0 risk factors, not high cholesterol, not high blood pressure, not diabetic, not smokers. And, a fair amount, probably over half, are going to either have a small amount of CAC, which is here, 1 to 100, and even a few up here are going to have a CAC greater than 400. So even though they have no described risk factors in terms of the big 4, they have a very high burden of calcification. So it definitely adds incremental information to what we sort of traditionally measure at a clinic visit in terms of cholesterol, diabetes, smoking, and so on. Now, it definitely impacts longevity. And so these are just some graphs that show the likelihood of surviving over about 14 years. These are those people with no risk factors. And the red right here is those people with a high CAC score more than 400. As you can see, they're not going to live as long. So it definitely impacts prognosis to get the CAC score. And again, here you see people with lots of risk factors, two or more. If you have a high CAC score, this is not the group that buys the economy size peanut butter. No, I'm kidding. But it is, that is a very high risk group. And so it is now recognized that getting this CAC score can help better define risk. And for me, it kind of takes us out of that prediction, fuzzy logic world and puts you into the concrete, you got plaque. And so what are we going to do about it? Now, what are the recommendations from the guideline people who are way smarter than all of us is that basically say, if you're a low risk person and we would never recommend a statin, CAC is not cost effective. And if you're a super high risk person, we're going to recommend everything in the kitchen sink. So don't bother getting a CAC because it's not really going to change what we do. But where a CAC score might reclassify us in terms of being high risk or low risk is sort of in that in-between group. Now, I will tell you my own personal bias about this. I just showed you a slide that showed in those people who have 0 risk factors, which means they have low risk, about half of them are going to have some calcification, and a small number are going to have a lot of calcification. So I must say, if I have someone who has a high cholesterol, even if they have a low calculated risk, I think a CAC score is very helpful just to confirm that they are in fact low risk, because none of those risk prediction tools are perfect. In the situation where someone's super high risk and everyone and his uncle says, take a darn statin already, I have a number of patients who really don't want to. And they really say, yeah, my dad had a heart attack at 50, but he was Jabba the Hutt, and I'm like a granola eating, jogging, kale enjoying person. And it doesn't run in my family. It was just, my dad made bad choices. And even though my risk calculates is high, I just don't want to take it. And I'll say, okay, well, let's just get a CAC score and see, what the story is here. And if the CAC score is high, I can say, it's probably some genetic contribution here. And if the CAC score is 0, I really feel comfortable saying, even though your risk is high, you're not making plaque. And if we want to work on lifestyle a little bit, I'm okay with that. And again, these are in asymptomatic people who have not had events. If you come to me and say, I have crushing substernal chest pain that goes down my arm and makes me sick to my stomach, and I can't walk 3 steps without collapsing, then obviously all bets are off. But I think for prevention in an asymptomatic population, I think CAC scoring can be extraordinarily helpful. So I know I have talked way over my time allotment. So Dr. Defina, if we have time, I'd be happy to answer any questions.
Well, perfect. First of all, Dr. Radford, thank you for an absolutely excellent lecture on risk prediction, and thank you for helping us in our quest to continue to improve the quality and quantity of life. So yes, there are a couple questions, and I'll start with the first one. One attendee wanted to know the question of whether, is there any danger to getting a CAC score? You got to get in a CT scanner. So where's the risk versus benefit of that?
That is a great question. So, I kind of consider that there are 2 risks with the CAC score. So number one is, it costs money. I don't really think it's covered by many insurance plans, universally. And so often people will pay for it out of pocket. There are a lot of places that, don't charge very much. And I think it's a worthwhile investment because it can really change how we create a risk prediction or a risk reduction strategy for you. In terms of risk, it's radiation, and the radiation exposure is quite low, less than a millisievert. And to kind of put that in perspective, sitting on the face of the earth, we get about 3.5 millisieverts a year from the sun, which is our greatest source of radiation. So for me to get a CAC score that's going to meaningfully change, again, how we protect you from fatal and non-fatal stroke and heart attack, I think it's a reasonable radiation exposure.
Excellent, thank you. Okay, the second question is, can the calcification score get lower? And if it can, how do I lower my score once it's present?
That is a great question. So the presence of calcification cannot be reversed. Once you have a CAC score, it's just part of your sparkling personality. And there's a good chance it's going to go up over time, even if you aggressively control your risk factors, because the process of calcification, inflammation in atherosclerosis is kind of like a giant battleship. It's got this huge amount of entropy and it's hard to stop on a dime. But one thing that we do know about, for example, starting a statin medication is, even though the CAC score does not change, we know that it dramatically reduces the risk associated with that CAC score because it stabilizes the plaque and it reduces it from rupturing. And of course, Laura and I have published a paper together in the last year or 2 or 3, because how time flies, showing that in fact being fit also reduces the risk associated with a CAC score. So we know that when you have a CAC score and you have a burden of atherosclerosis demonstrated by that CAC score, you really can change the clinical ramifications of the score by risk factor control, but the score doesn't go away.
Excellent, thank you. And I think the last question that we have time for is to focus in on a group that we have interest in, which is endurance athletes, and we certainly have done some work together, but there is some literature that says endurance athletes, so marathon runners, triathletes, might have a higher risk of coronary calcification. But do they have a higher risk of dying from that calcification? And just because they're such an elite athlete, should you not put them on a cholesterol medication?
So that's a great question. And in fact, we have published on that in the recent past because that's a big concern of people who've been longtime endurance athletes, is whether or not they're putting themselves at risk to continue. And again, our data and the data of others show that the calcification value is higher in endurance athletes compared to matched controls who are matched for age, gender, risk factors, and so on. But it appears that these athletes do not have an increased risk of dying from coronary disease, even though they've got a higher CAC score. And it may be that their calcification is based on some different mechanisms, biologic mechanisms, than sort of the typical CAC that you get from having, high cholesterol and bad lifestyle choices. I definitely, if I have a patient who has, a CAC score and a cholesterol that really suggests they would benefit from a statin drug independent of their endurance activity, I would absolutely recommend the use of a statin drug in that situation.
Perfect. Well, Dr. Radford, thank you so much. And I know that there are other questions out there, but we have used up our time. So to close today, I would very much like to invite you to our next Coffee with Cooper, which will be on Thursday, September 23rd, with Dr. Tyler Cooper, who is a president and chief executive officer of Cooper Aerobics. He will talk about the importance of fitness in solving America's healthcare crisis. Again, thank you all for coming. Thank you, Dr. Radford, and everybody have a great day. Bye-bye.
Bye.